We're going to take this maxillary occlusion rim and we're going to fit it to our patient's mouth. Generally, the way we do that is we're going to place this rim in our patient's mouth, and we're going to look at a couple of planes first of all to see how well we're doing as far as planes are concerned, meaning a anterior-posterior plane this way and a lateral plane, to make sure that we have that maxillary plane, both the incisal plane and the anterior-posterior plane, in a good relationship for aesthetics and for function. A good aid in helping us in establishing that plane is called a TrueBite occlusal plane guide, that was developed by Dr. Fox. So we call it a Fox occlusal plane guide, and that's used by use of a tongue blade and this Fox occlusal plane guide by inserting this into the patient's mouth and hold it against the existing occlusal plane. And we want to do two things with it. We want to find out whether or not the incisal plane that we've started with, whether or not that plane is parallel to the pupils of his eyes. So what we do, I want you to look right there, straight at the bridge of my glasses, and I'm going to see if that plane is parallel to the pupils of the eyes. And it is. The other plane that we want to look at is an anterior-posterior plane to see if the occlusal plane is going to parallel the ridges. We do that by analyzing a plane from the ala of the nose to the tragus of the ear. So if we lay a straight edge from the ala to the tragus, that should parallel the occlusal plane. Is that what they look like, Dr. Winchie? Parallel? I should have made those longer, shouldn't I? Come out too straight. Now, next thing we want to do is we have established that this occlusal plane is roughly parallel to the norms that we might look for as far as where the occlusal plane and the incisal plane should be. The next thing we want to look for is lip length. We want to determine where we would like the incisal edges of the maxillary teeth to be, so that we can establish how far down we want to place those teeth and somewhat how full do we want to make this lip. Okay? A good way of doing that is to look at your patient's lip and just see what we have. With this particular patient, we have a fairly flaccid lip, and if we look at the amount of red part of the lip that's showing, it's in pretty good condition. It shows a fair amount of the red part of the lip, which means that the fullness that we have built into that rim at this point is not too bad. If I had to change it anyway, I would make it just slightly fuller. And perhaps what we will do when we get to arranging teeth is, instead of arranging the teeth this far back into the mouth, we will pull them out just a millimeter or so and make them just slightly fuller than what this rim is for this particular patient. As far as the lip length is concerned, we want to look and see at what level would we like these incisal edges, because if we leave it at this level, this is where the incisal edges of the maxillary anterior teeth would belong. And so what we want to do is we can use some phonetic exercises somewhat to help us to analyze if that's where we would like that. We also can use just plain old common sense about, if this patient had natural teeth, where would the incisal edges be? The normal is that the incisal edges will show when that patient is totally at rest and just part the lips enough that we can see. We barely show the edge of that rim right there. With this particular one, it's slightly up under the lip, about a millimeter. So we might want to consider lengthening that incisal edge when we arrange teeth by just a slight amount. Let's go through a little phonetic exercise and see what happens. I would like you to say 444 for me.
444.
444.
444.
Now, he lacks a little bit of the incisal edges of that wax rim that's there being able to touch his lower lip. And with the F and V sounds, and if you select words that have a lot of F and V sounds in them and have them pronounce them, such as 444, 555, fan and van, vantage, words such as this, then the incisal edges of the maxillary 6 anterior teeth should make a firm but not displacing contact with the lower lip, and that contact should occur, if you'll open just a little bit, at the junction of the wet mucosa and the vermilion part of the lip. You can see a very definite junction on his lip. That contact should occur right at that junction. So now say 444.
444.
555.
555.
And if they were a millimeter longer, we'd be right on it. Okay? All right, let's see if we can turn you this way just a little bit. Now say 444.
444.
555.
555.
And as you can see, he likes a little bit right here making contact on the F and V sound. As far as its anterior posterior position, it looks pretty good because it's contacting right on that what I call wet dry line. Okay, now just turn it back around this way. Now that we've established that we think this plane is pretty well what we would like it to be, and that's strictly by accident, believe me. They don't usually come out that way. They usually are too long and you have to cut wax back to get it to that point, but that's okay. We first of all would like to see on our patient what we think is the vertical dimension of occlusion. We find the vertical dimension of occlusion by first of all trying to find on our patient what is the vertical dimension of rest. The vertical dimension of physiologic rest is the relation or the dimension of the face when all of the muscles are totally at rest. So this is what we have to establish before we can establish a vertical dimension of occlusion. Vertical dimension of occlusion is going to be slightly less than the vertical dimension of rest so that we can end up with a freeway space. And we establish this by several means. You can use little patches of tape if you wish. Sometimes I use them, sometimes I don't. And put a little patch of tape on the patient's chin, and we usually try to do that at a point to where the apex of the curvature of the chin, that you have that covered so we can put a mark on it. We do the same thing on the tip of the nose by putting a little tape on the nose, if I can get it to stick. What I generally like to do with this now is put a little mark on that. Now what I would like to do is use some method of measurement, and usually a tongue blade does well for this, by putting a mark on the upper part of the tongue blade, steadying it on the mark that's on the nose, like so. And now I'm going to ask you to say some things and do some things, and let's see where you end up for resting. I want you to totally relax your jaw and don't show me anything. Just let it relax and stay there, okay? Let's put a little mark right there. That's one guesstimation of where the vertical dimension of rest is. Now, I want you to wet your lips with the tip of your tongue. Just stick your tongue out, wipe it right across your lips. Now relax and don't show me anything. Just let it go where it wants to. And that came out pretty close to the original. It's maybe a millimeter and a half farther open. Right there. Now I want you to relax again. Wet your lips again. Now this time I want you to say Mary.
Mary.
Okay, now try Emma, Emma, Emma.
Emma, Emma, Emma.
And relax. And lo and behold, we find he goes back with the phonetic arrangement to this first guesstimate that we had, which is a little farther closed than when I was just judging him when I thought he was relaxed. Okay, now let's try another one. Okay, say Emma, Emma.
Emma, Emma.
Now say me, me.
Me, me.
And you notice after he pronounces words with M's in them, like Emma, Emma, and me, me, and Mary, and he relaxes after that, he's right on the mark that I show there as being the vertical dimension of rest. So I'm going to accept this dimension between this point and this point, measured from this point and this point, as being the vertical dimension of rest. Now the object is to establish a vertical dimension of occlusion which is going to be slightly closed from that, somewhere between 1.5 and 3 millimeters usually. So I want vertical dimension of occlusion to probably end up in just about that dimension between those 2 points rather than this dimension between the 2 points. And the reason being that would have his jaw further closed than the vertical dimension of rest. First of all, let's seat the maxillary base plate and occlusion rim in the mouth. And now, rather than having only one base plate and occlusion rim in the mouth, we're going to have them both in there at one time. And you're going to feel like you really have a mouthful. So we're going to insert the other base plate and occlusion rim. Now I want you to open just a little bit and bite my fingers just to make sure they're seated real well. That's good. Now I want you to just close to let them touch each other, and it's hitting right now in the front before anything else. Now just keep them clamped together there and let me see. And as you can see, we know this is open because he has a hard time getting his lips together. So immediately our first impression is that the vertical dimension of occlusion at this point is too far open and we need to close it down. So let's measure and see. And yes, we can see we need to close it from this point where it is up to this point, which means we're going to have to take wax off of that lower rim in order to be able to close it that much. And we've determined that basically when we have this base plate in the patient's mouth, that the vertical dimension of occlusion is too far open, which means that since we've already established an occlusal plane and an incisal plane and an incisal length, any reduction now of the vertical dimension of occlusion would come off of the lower rim at this point. Remember when we saw this in the patient's mouth and he was too far open, it hit only in the anterior part, and the posterior parts of it were open and were not hitting. So in reducing this, we want to reduce more from the front than we do from the back, and we want to reduce 3 or 4 millimeters in the anterior region, and then we'll try it back in the patient's mouth. We're going to do that by heating a hot plate in the Bunsen burner, get it real nice and hot. And we'll get this hot plate hot enough till it will melt wax for us. And once the hot plate is hot, we're going to melt wax off, melting more off of the front than we do off of the back, so that we're going to reduce it 3 or 4 millimeters in the anterior without reducing very much in the posterior. That's my guesstimate of how much to take of the first try at it. So from here, we'll go back to the patient's mouth, and we're going to seat it. And this time I want you to bite my fingers again now, just like we did before. You're not going to hurt me, okay? Now open a little bit. Now close until they barely touch each other. And this time when they close, it's hitting in the posterior just very slightly before the anterior, but not much. It's almost where we would like it as far as contact is concerned. And now we want to judge, we want to check and see if that dimension is closer to what we wanted vertical dimension occlusion to be, or if it's still open. It's still open a little bit because right now we have it almost on the vertical dimension of rest. So I want to close it just a little bit, maybe a millimeter or two, and I want to do that by taking slightly more off of the posterior than I do off of the anterior. Not much though, just a little bit. So we're going to heat the hot plate again. And this time we'll reduce a little bit more posteriorly than we do anteriorly, but not much, just a tad. And we only want to close in the incisor region, we want to close it maybe 2 millimeters. So we're going to take a little bit off posteriorly and very little anteriorly. And if you end up with an area that is rough on the posterior of it, like here, just take your knife and cut that off, so that does not become an interference for us. Now we're going to take this back to the patient's mouth, and once again check the vertical dimension to see where we are, and check to see our contact is coming. Bite my fingers again now. Good. Now open a little. Now close till they just touch each other. Good. We have almost even contact all the way around of the rims at this point. Now let's see where vertical is. If the vertical dimension of occlusion is closed to the area that we wanted it. Still slightly open, as we can see here. At this point, you may want to start checking phonetics. You can check the vertical dimension of occlusion by having the patient go through lots of sibilant sounds, and those sounds should show you, as they are making these sibilant sounds, should show you that the jaw bounces up and down as the patient talks, and the object is to get this dimension in here in such a manner that as that jaw moves up and down, the lower teeth almost touch the upper teeth but do not quite touch them. If they touch them and bump them, they're too far open. If there's a big space in there as they go through the sibilant sounds, then they're too far closed. So what we want to do is we're going to check that by having you wet your lips again now. Now say, I want you to say 777.
777.
Say 777.
77.
Say some chicken.
Some chicken.
Say church.
Church.
Judge.
Judge.
Okay, as we can see, as he's going through the sibilant sounds, he bumps. The lower rim comes up and bumps the upper rim just slightly, which means that we're still slightly too far open. We need to close the vertical dimension down just a little bit more, and we're going to do that by removing more wax from the mandibular occlusion rim to close him down another millimeter or two. And then we'll check vertical dimension of occlusion again. So we're going to melt a little wax off. This time not only are we going to check the wax for contact, but we also need to check to see if we perhaps are getting an interference of the plastic of the base plate on the posterior of it on both sides, on either side, if we're getting an interference with the maxillary rim. So let's see where we are at this point. I'm going to place this in the mouth. Bite my fingers again. Now close until they just touch each other. Hitting more posteriorly than anteriorly now. Now let's check that dimension again. Now it looks like well, maybe not. Looks like we may be right on it as far as that dimension is concerned. Okay. Now we're going to wet your lips again. Now say 444.
444.
777.
777.
Say some chicken.
Some chicken.
Say church.
Church.
Judge.
Judge.
Emma.
Emma. Emma.
Say me.
Me.
777.
777.
All right, now we watch that jaw. It has more freedom of movement now than it had before. And the teeth come up and approach the lower teeth, or the lower wax rim actually, approaches the maxillary wax rim but doesn't touch it. At this point, it's always a good idea to look in the mouth. I want you to clamp your teeth all the way together and hold it a minute. And we're going to look way back in the back. I doubt the camera will be able to get to this, but if you can't, that's fine. I'll try when I see what we got here. And yes, I have an interference back there, not a base plate to base plate, but I have an interference of wax to base plate. Now, let's see if we can see way back here the posterior end of that maxillary rim. Can't see it? Okay, don't worry about it. All we're going to do, just move your head back. Open, please. We're going to take them both out. What we find is interfering is like this. And the lower base plate, the retromolar pad coverage in this area is interfering with the posterior end of the wax on the maxillary rim. So all we need to do with that is we will take a knife and just cut some of this wax off. And cut a little on both sides, because I suspect if one side's doing it, the other side may at least be close. So we cut a little of the wax off, and we'll try it back in the mouth now, and let's see what happens, see if we still have that interference. All right, now clamp them together. And just checking for interference. Now we have a total clearance back there now. There is no interference of any type. We may be able to see this if we turn your head way around here now, close all the way, and we can see back there a space. We have no interference. We only have wax touching wax. And the same is true on both sides. Okay, back around now. We're going to check the vertical dimension of occlusion once again. This is very important that we get this correct. And so we're going to look with those clamped and see where it is. All right, now, right now he has his lips pursed just a little bit. Try to relax a bit and keep the teeth clamped together. Slightly too far closed according to this. Now that can come about you can get fooled about vertical dimension of occlusion by interferences. And we had a slight interference on the left side, which was throwing our judgment of the vertical dimension of occlusion. So what I want to do is I want to open him back up just a little bit. Now there's two ways I can go about that. I can go about that by taking a piece of base plate wax and making a little rope of wax and placing it on the lower and build it back up with wax. Or I can do that with our interocclusal record, our record of centric relation, by just recording it with it a couple of millimeters open, rather than with allowing these rims to come all the way into contact. As we record centric relation, we will record that with them about 2 millimeters open, and that should compensate for it. Okay. Now we know where vertical dimension of occlusion should be. We know where vertical dimension of rest is. The object now is to record the relationship of his mandible to his maxilla, and also not only to record the relationship of his mandible to his maxilla, but also to record the relationship of his maxilla to his skull. And that's what we do with a Facebow transfer. And the next procedures that we want to do is to record vertical dimension of occlusion and the centric relation, and also to record a Facebow transfer so we can properly mount the case on an articulator. The starting of that is to cut some keyways into your occlusion rims. And we're going to do that by cutting keyways into the maxillary occlusion rim. First of all, I like to use small V-shaped grooves into the rim and make sure the grooves are not parallel to each other. We would like those non-parallel grooves, about 2 grooves on either side of the posterior at about that size, as you can see. About that size. And we're going to do that on both sides. Cut a couple of little grooves, little V-shaped grooves on each side. We're going to do the same with the mandibular rim by cutting small grooves that are non-parallel to each other. Cut 2 in each quadrant. Now the face bow that we're going to use is called a twirl bow. No, I'm sorry, that was the old model. This one is called a spring bow. And as you can see, it has earpieces on either side, and it has an infraorbital pointer. And it also has a gadget in the front that's used to attach the attachment mechanism. The attachment mechanism consists of a vertical rod, a horizontal rod, and 3 little screw devices that with thumb screws on them to allow you to tighten them in the correct position. So we're going to loosen everything up and insert this vertical rod into the hole in the bottom of the anterior part of the face bow, like so, all the way up to the O-ring. And notice that there is a flat spot on both the top and the bottom of that vertical rod. That flat spot must face forward. Then tighten the screw on the face bow, and that has this vertical rod attached to the face bow. These 3 screws should always face outward, so that never face inward like this, or you wouldn't be able to tighten them very well. They should always face outward, and in doing so, they will be on the left side, or patient's left side of the face bow. Make sure they're always on the left side of the face bow. Since those screws are going to be on the left side of the face bow, the face bow fork will come out of the left side of your patient's face. It must be out of the left side of the patient's face. Now the way we operate this is we have heated a cake of red cake compound in a 140-degree water bath. I'm going to take that compound and form it into a small hot dog and wrap it around the face bow fork like so. Attach it to that face bow fork while it's warm and soft and pliable, and then we're going to seat Got it on the wrong side, don't I, Dr. Winchy? I've got to turn it upside down. Did it wrong. Good lesson. It's got to come out of this side of the patient's face, the left side. I had it on there in such a way it's going to come out of the right side, and that doesn't work. And once you have the, and we're going to seat the base plate that we have now with those grooves in it into that softened compound so that it is very well seated into it. And once it's seated, if you separate it, you'll see a nice imprint of the occlusal surfaces of the maxillary rim into that compound. Now I'm going to chill that compound so that the compound is hard, and this base plate now will fit back into that compound exactly as we first seated it. Now we're going to the patient's mouth, and this whole thing is going to be seated in the mouth. Okay, now I would like you to take your thumbs, one on either side, and right there, and hold that firmly in place. And have your patient hold the fork with the compound on it firmly in place. The easy way I found of doing this now is with everything all loose on these 3 thumb screws, make sure they're nice and loose, is to thread the fork onto the attachment mechanism and spread the Facebow and put those earpieces into the outer meatus of each ear. Now that should just feel very snug to you but not hurt. Okay? And with him holding this firmly in place here, bring your infraorbital pointer around, and with this particular case we want it to lower it a little bit. Basically this infraorbital pointer should point to the inferior border of the orbit. And that's at that level right there. And with the infraorbital pointer in place and it firmly into the outer meatus of both ears, hold it firmly in place, and the thumb screws are marked 1, 2, and 3, and tighten them down in the order in which they are numbered. And go back and retighten them so it doesn't slip. Now, we can remove this from the patient's face now. Now just turn it loose, and the whole thing should come out. And now we have a Facebow transfer that will help us orient the maxillary cast to the articulator. Now we can set this Facebow transfer aside now, and we're going to work now with centric relation. Remember the definition of centric relation, and this is probably the most, it's the make or break of most patients of whether or not you are successful with the occlusion with a set of complete dentures. Many ways of getting the patient into centric relation, and we're going to just practice a couple of them before we try to make the record. Okay? We're going to place both rims in the patient's mouth. Now, there are many things that you can do to get to convey to your patient what you want them to do. Basically, you're trying to convey to your patient that you would like him to put the lower teeth as far behind the upper teeth as they'll go. There's many ways of saying that. Is to put your lower teeth as far behind the upper as they'll go is one way. Another way is to put the upper teeth as far in front of the lower teeth as they'll go. That will sometimes get it. You can tell the patient that what I want you to do is to pull your jaw as far back as it'll go and close. Another one is to curl the tip of the tongue as far down your throat as it'll go and close. And then we want to record. Now I want you to close with that tongue way back and just close. There we go. Open a little bit. All right. Now I want you to put your lower teeth as far behind the upper as they'll go and close. He goes right to it and you can feel it. Okay? So we're going to need to record that. Right now you feel a little more pressure on the right side than the left side. Is that correct? Yeah. Okay, we've got to equalize that pressure in making our record. Okay, open now. Now the medium that we use for making this centric relation record is gray stick compound. And it's used in the same manner that you use gray stick compound for border molding. And we're going to place compound on that lower rim, and it's in its very softened condition with compound on this lower rim. We're going to place it in the patient's mouth, have him go to centric relation and close. That's the way we're going to record centric relations. So we're going to place the compound on the lower now by just heating it in our flame. And apply that compound to the occlusal surface of that mandibular rim. I'm not getting it to adhere very well, but it generally does after a little bit. Okay, and we're going to get enough compound to get a record applied to that mandibular rim. Once that compound has been applied to the rim, temper it in the water bath, get some wet fingers on it, and build that compound up into a peak along both sides. That record should run all the way from the canine back through the molar. Don't get a little short piece of compound on it back in one tooth wide and expect to get a record. It doesn't work very well. So once you have the compound applied to the rim, then take your torch, like we did with border molding, soften that compound. It's superheated, nice and soft. Then we're going to temper it in the water bath, just as we did with border molding. And we're going to take this to the mouth now. Seat it well. And we want you now to curl that tongue as far back as it'll go and close very gently. Just a little more. Hold it right there. Now, remember we said we wanted to open vertical dimension a couple of millimeters, and that's what we've done. Leave it open about 2 millimeters in the incisor region. Open now. At this time, they usually will both come out of the mouth at one time. If they don't come out one at a time, it's okay. But as you can see, we have a very nice clear recording of the occlusal surfaces of the maxillary into the compound on the lower. Now the idea is to find out if that's accurate. And the way we're going to do that, make sure that it will orient properly in your hand, and it does. Now let's see, if we go back to the mouth with this now, let's see if it closes the same way and meshes exactly the same way. Now close again on the back ones only. It does not. It's hitting on his right side slightly before the left side, so I want to redo that. And we're going to do that by simply, at this point, leave the maxillary in place, and on the lower one, reheat your compound with a torch a little bit, get it nice and soft. And now we're going to temper it. And this time I want to go a little slower with it, okay? There. All right, now tongue way back and close straight up slowly. Closely, just barely touch each other. Now just a slight bit of pressure to mash it. There we go. Now open. Again, we have nice clear demarcation. We'll chill it a little bit now. Take it back to the mouth. Now close again, same way. All the way back and close. Straight up. And this time it meshes perfectly, both sides at the same time. Sometimes I find that I can do it by placing my fingers, my forefingers, over the buccal shelf area of the lower and thumbs underneath the chin a little bit, and you do not push on the patient. You allow the patient to go back on their own. Okay, you just make sure that lower is held well in place and have the patient carry the jaw back and close. All right? That's one way. That works well if the maxillary denture stays in place by itself. If the maxillary has no retention, it doesn't work so well. And in that case, the one that I like to use is this one. Now open, and that is to put the ball of the forefinger and the ball of the thumb between the occlusal surfaces of the upper and the lower. And as you hold the lower down, you also hold the upper up at the same time, and then I want you to carry the jaw back, all the way back like you did before, and close. And that way you hold both of them in place at the same time. Either one that you develop the skills to use is fine. There is really no preference with it as to which one. You will find that some instructors or some dentists like to do it this way, and some like to do it this way. Whichever way you can do it best is what you should be doing. Oh, by the way, let's go back to one other thing while we're here. Since we have that record and we have the two marks we started for vertical dimension of occlusion, let's go back and see how accurate we are in our guesstimate of how much to open him with the record when we place the record in it, and see how close we came. There it is, exactly on it. Good guess, huh, Dr. Winchy? Bingo. Okay. What we're going to do is we want to mark the midline of our patient's face. And I don't think it's necessary to move the camera to get this, but basically all we're going to do with a piece of dental floss is to figure out what is the midline of the face, which appears to be right there. Now open, please. Now let me see your upper. Can you raise the upper lip a little bit? Not really. Yeah, there you are. Now let's see. All right. Now let's see. Close again now. Now let's see the upper. Yeah, right on it. So all we're going to do is we're going to mark, and I'm not going to cut you with this, I'm going to take a knife and I'm going to put a little mark on the wax of exactly where the midline is, as determined from the patient's face.